Thank you, Sarah. So the last few days have invited us to think really deeply about gender affirming care, HIV, PrEP, kink, which is fun. And today we're joined to talk about reproductive health care for the LGBTQ community. We have sessions on sort of the full spectrum of family planning, including contraception and abortion and fertility care and maternity care. And one thing that I'm really excited about today, talking about contraception and the intersection here, is that it forces us to challenge our assumptions about sexual behavior and contraceptive need. And what we've heard the last few days is that all kinds of people are having all kinds of sex with all kinds of partners with all sorts of parts. And so whether patients need a contraceptive method to prevent pregnancy, or for reasons that have nothing to do with pregnancy, maybe to suppress menses and manage gender dysphoria. We know that all patients deserve care that is respectful and responsive and hopefully transformative. So Dave and I will spend the next 50 minutes talking about contraception, and you all are here today as providers who don't provide contraception. So what are you doing here, right? No, you're in the right place. And I was really encouraged by what Mary Fisher said on day one. You don't have to be a sex therapist to have sexual health conversations with your clients. And the same thing is true about contraception. We know that you have earned the deep trust of a lot of your patients who have been alienated from the medical establishment, and that makes you excellent ambassadors for providing information and answering questions that patients might have. So you are in the right place. So today, what are we going to talk about? I have some objectives here, and as I was typing these out, I realized that for a topic that is essentially about sex, these are very unsexy, especially at 8 a.m. So I have re-envisioned them as BuzzFeed clickbait listicles. So we're going to talk about family planning mythbusters and really examine some of the concepts and thinking that the family planning field, those of us who have been working in this field for years, have had to grapple with as we confront new frameworks that challenge those beliefs. Number 3 will shock you. And then I'm going to turn the mic over to my friend and colleague and mentor, Dr. Dave Turok, to introduce the methods themselves and take a look at how we can group them and assess them and think specifically about considerations for transgender and gender diverse patients. And if this leaves you craving a more in-depth look at the methods, you are in luck, because Dave will be hosting a session that does take a deeper clinical look at each of these methods later today. And then finally, there are so many great resources out there right now on contraception and job aids and tools that you can use for yourself, for your families, for your clients to really support your decision making. So we'll cover a few of those. All right, so let's dive in with this statement. Contraception is an unmitigated good. What do you think about that? Show me with your faces. Yeah, maybe. I mean, contraception is pretty rad, considering that the average person capable of pregnancy in the US will desire about 2 children and spend about 3 years being pregnant or attempting to be pregnant. That leaves the better part of 3 decades that we rely on contraception to space and limit pregnancies. So yeah, thank you, birth control. And these images come from the Bedsider Thanks Birth Control campaign. But many of us do associate contraception with empowerment and autonomy and women's liberation and pictures like this. But it hasn't always been sunshine and rainbows and hearts and stars. We don't need to dig back too far into history to see the darker side of the field of contraception. For as long as these methods have been around, they have been used as a tool to limit the reproduction and fertility of marginalized groups based on race, mental and physical ability, and socioeconomic status. And I'm sure you've heard of some of these examples: forced sterilization in the 20th century, incentivization of Norplant to Black women on public assistance in the 90s, up to today with unconsented sterilization at ICE camps and policies that maybe cover the cost of IUD and implant provision, but not the cost of removal. Some people have had to fight just as hard for their right to have children as to not have children, and that persists today. So is contraception an unmitigated good? No. It's a great tool for achieving reproductive autonomy, but it's also a really dangerous tool for reproductive oppression, which is why contraceptive provision requires the utmost thought, consideration, and wisdom. And speaking of wisdom, we have Black scholars and activists like Loretta Ross, pictured here, to thank for the reproductive justice framework, or RJ, if you want to sound really cool. So the framework is not new. This dates back to 1994, but it continues to really challenge and shape and improve the field of family planning by reminding us that contraception is really just one piece of this larger puzzle. RJ affirms that everyone has the right to have a child, not have a child, parent children in safe and healthy environments, and some iterations even say it's your right to enjoy sexual intimacy. So approaching contraceptive provision from an RJ framework means that we have to ask questions like, can patients access the method of their choice? Can they discontinue it when they want? Can they access abortion if contraception is failing them? Are there concerns about side effects and sexual pleasure taken seriously? And when we ask these questions, we also are forced to examine whether contraceptive care is provided to individuals differentially. Does someone's race, age, sexual orientation, gender identity, mental health status, use of substances play a role in how their care is provided, what methods are discussed? And research tells us that it actually does, that our implicit or explicit biases about who we think should be having children impacts the reproductive health care that people receive. The Black legal scholar Dorothy Roberts once said, "The thing about reproduction is that more than anything else, it tells you how a society values people." And what the RJ framework does is equips us with this essential Bill of Rights, affirming that even the most marginalized identities, and we can include the LGBTQ community, are entitled to these freedoms. All right, let's move on to another concept. Let's see, contraceptive decision-making is simple. So I don't know, do you have one of these internal switches? It's just on and off. So one day you want pregnancy, maybe the next day you don't. It's very simple, there's no dimmer, right? And that also our decision-making around contraception is very linear and predictable and simple, super simple. I'm gonna call BS on that. That is not true. So qualitative research tells us that those internal switches maybe look a little bit more like this. And at any given time, somebody may desire pregnancy, but also maybe not desire pregnancy. And that state of pregnancy ambivalence is really, really common. Yet our reproductive intention screening questions and contraceptive counseling techniques haven't always done a great job taking that into consideration. We've also had a fairly simplistic understanding of the path that individuals take. But researchers like my colleague, Rebecca Simmons, have actually studied the path that folks take from initiation of contraception through different methods and looked at what influences people to switch methods. And it's very common. We know that the average person using a reversible method of contraception from the age of 15 to 45 will discontinue based on method-related reasons, an average of 10 times, which is a lot. People's goals change over time, and contraceptive use needs and priorities also change across the lifespan. So specifically, contraceptive journeys research shows how changes in physiology, like side effects, values and desires for pregnancy, relationship status, life circumstances, and other experiences affect that path. One thing that I really appreciate about this contraceptive journeys lens or approach is that it really changes our framing of how we conceptualize the user of contraception. So in the past, we might have thought, oh man, this patient is so non-compliant, right? They're not using their pills. Oh my gosh. Or they tried the patch for a month and now they want to try something else. And so instead of thinking of the patient as being flawed, we really are able to now see that it's the method that's flawed. It's just not a great fit. That patients' lives are really complicated, and they do have complex internal algorithms for thinking and deciding about their reproductive choices. So this way of thinking normalizes method switching and lets us see that it's the rule, not the exception, that people will try out different methods over their lifetime. It underscores the importance of making a variety of methods available and acceptable and affordable so people can maximize their chances of finding a match. It challenges us to develop new methods that haven't existed. And then it also reframes the role of the counselor or the provider. In the past, it's the provider's responsibility to keep this person pregnancy-free, right? And to help them find their forever lover of a method. But what happens if somebody stops using their method, switches, discontinues, maybe gets pregnant? We have in the past, providers have made to feel like it's their professional shortcoming when that happens. But in reality, it's just all part of the journey. I think it can be really professionally freeing for folks to look at this graphic, which depicts the qualitative research that my colleague, Dr. Simmons, has undertaken in the last few years. And it shows those contraceptive journeys, starting on the outside, and then as they continue with method selection towards the inside. And we see just how common method switching is, how willing people are to try to find something that does fit with their lives, and sometimes how exhausting that journey can be. The method a person chooses after contraceptive counseling, honestly, it may be short-lived, right? They may only use that a couple weeks or a month or who knows how long. But how a patient felt in the process and the accurate information that they took with them along their journey, that is what can have reverberations years down the line. So with reproductive journeys, we see that it's not just about the outcome, but it's about the process. Okay, and last but not least, this is the one that's supposed to shock you. Counselors should urge patients to select a highly effective method of contraception. What do you think? It's not fair because you're set up to know this is a myth. Yes. On face value, this sounds reasonable, right? Like, why not get the thing that's the best at doing what it's supposed to do? After all, these are the methods at the top. They have 5 stars. Look how great, and there are not that many pregnant bodies next to it. Why wouldn't you want these methods? And the answer is that, well, a lot of people actually do want highly effective methods. How well a method protects someone from unintended pregnancy is a top consideration for a lot of folks, but it's not the only one. For some people, the ability to discontinue without a doctor's appointment, hormonal side effects, cost, privacy, and non-contraceptive benefits are very important considerations in choosing a method. And we know a lot of providers and programs and public health initiatives are super excited about IUDs. And again, it's not hard to see why. And when we establish reduction of unintended pregnancy as a population goal, as something we're all trying to do, including providers, then this may look like the solution. But the problem is that we work with individuals, not populations. And many individuals exist somewhere in that murky middle between wanting pregnancy and not wanting pregnancy, or having preferences that don't align with these top highly effective methods. So instead of encouraging patients to select a method based solely on effectiveness, counselors should elicit their patients' preferences and review contraceptive options that align with those preferences. It's not rocket science, but it does involve a pretty fundamental shift from centering the needs of public health to centering the needs of patients, even when those are in conflict. And the great irony is that when care is delivered in a patient-centered way, by being genuinely curious about patients' lives and what methods will work for them, we actually do see higher satisfaction and longer continuation of the method, even though that wasn't the goal. And even more good news is that we now have a way to measure person-centeredness in contraceptive counseling. Researchers at UCSF have distilled this down to 4 things that we want every patient to say when they walk out the door: that their provider respected them as a person, let them say what matters to them about a method, that their provider took their preferences seriously, and that they were given enough information to make a decision. So when we take away the goal of reducing unintended pregnancy, take the goal of having patients select an IUD, we now have a more noble goal and one that defines success for contraceptive counseling. So I'll leave you with the closing line from an article by Eileen Gubrium that perhaps says it best and oftentimes makes me tear up. The quality of contraceptive programs should be based not on how many LARC methods they distribute, how many adolescent pregnancies they prevent, or how much money taxpayers save, but by how many people feel truly respected and cared for when it comes to childbearing and family formation. All right, thank you. With that, I will turn the mic over to Dave to tell us a little bit about the methods.
Right on. Good morning. And this ought to be really, really good because you're missing Kate White in the other room. And it is stellar. And one of the absolutely beautiful things about Caitlin, and I've heard her talk many times, probably the first time for you all, is that every time she manages to do this amazing thing where she becomes more sophisticated and nuanced in her thinking, and then comes up with this simpler way to communicate that more complex thing. It's like absolutely beautiful and magic. So thank you for sharing that one more time. And I just want to share with you all, I have this very deep dislike for hypocrisy. And I want to acknowledge that I have transitioned from all of those myths to fact that Caitlin reviewed, and in large part with the guidance of herself and many of our other colleagues. And I am incredibly appreciative for that. And for me, the way that that comes out, that sentiment, and even that last slide, like I've heard, I have spent a lot of time with Christine Dellendorf, and like the person who is the author of that last paper. That slide's still up. And seen, like, you know, we're kind of the same age, and you know, I've seen her thinking evolve as she really developed this approach and this strategy. So I've heard her, you know, communicate this a lot. I don't think I've ever actually heard her communicate it as well as Caitlin just did. Very, very cool. So we can all learn things. And the way this has come to evolve for me, and you know, I'm embarrassed to say, like 25 years in, this is where, that's how long it took me to get there. But when I, you know, the way that I kind of live and share that now with people that I see for care is every time that I walk into a room to care for somebody, regardless of whether it's in the clinic and somebody's coming for contraception or an abortion or miscarriage, or I'm walking into somebody's delivery on labor and delivery, or meeting them before a surgery, I say, hi, my name's Dave Turok. I'm the doctor. My job is to make sure that you get the best medical care, and when you leave here, you feel respected. And that, like, does 2 things very quickly. it communicates to people like you're in charge, and you're like, you feeling respected is top priority. And, it also forces the provider, me, to live to that, because they've just seen and heard you say that, and can bring that back to you at any time. And it internally, I think, for me, drives like, you better live up to that. So there are quick and practical ways to deliver that message, and that's one. And I'm sure you all have other ways to do it. So just a little background about reproduction and contraception. The bottom line is, all of these methods that prevent pregnancy do so by essentially keeping sperm and eggs in different compartments. And there's a bunch of different ways to do that. But the thing that we are trying to do is either prevent an egg from coming out, prevent a sperm from getting into the place in the fallopian tube, the only place where they can actually fertilize an egg. And should fertilization happen, prevent implantation, which is universally among all scientific organizations on the planet, the definition of pregnancy is implantation. So anything that we can do to prevent that is fair game. And there's a bunch of ways to do it. And when we think about them in that framework, I think it's a little bit easier to break down the methods. And this whole process, it is quite miraculous, right? Like, we're all came from the same deal, one egg, one sperm. And that interaction that creates an entire new genome for a person, should it develop into a pregnancy. The initial cell to cell, 2 cells, 1 cell, and then back to a duplicate of 2 cells takes 24 hours. Like, there's a lot of information. And then for that to grow enough to implant and become a pregnancy is a week. So hundreds of and thousands of cells at that point. So this is the range of contraceptive methods. And one of the effective ways, I think, to thinking about how they can be used is looking at the framework and how they can do those things of, like, keeping the sperms and the eggs in their separate places and not making them get together. And if they do, making sure they don't develop. And all of these things on the looker's left there, for people who have a uterus, they all are hormonal methods that basically prevent the signaling from top down, basically. So in your hypothalamus, there's something called gonadotropin releasing hormone, and that basically sends a message to the pituitary, to these 2 other hormones, FSH and LH, and those send the messages to the gonads to do their thing, either develop a follicle and release an egg, or to the testes to develop sperm and release them. And you can, if you essentially interfere with that message in a very basic way, you can stop that process from happening. And because hormones are super complicated, they also act in a bunch of other places. So for example, like the birth control pill, this is the main way that acts. It prevents the message from in your brain of it triggering that hormonal cascade. And it basically tells your body, combined oral birth control pills, tells your body, like, hey, there's progesterone around. And it's not really progesterone, it's a progestogen. It's a synthetic version of progesterone, but it's enough to convince your body, or a person's body, that they're pregnant. And then when you're pregnant, that whole situation stops. You don't generate follicles and you don't release an egg. It also does a bunch of other things. So it has effects on the endometrial cavity, it can thin the endometrial lining, which is why there's changes in people's bleeding patterns and generally a thinning of the endometrial lining. And that's the most effective way to do that, is to deliver a boatload of progesterone or progestin right into the endometrial cavity through a hormonal IUD. But it also thickens the cervical mucus, so that can delay and make it more challenging for a sperm to pass through. So there's a bunch of different effects, but the main effect of all these things, the way, the driving effect to prevent pregnancy for all of the methods except for hormonal IUD, which thickens the mucus like incredibly, is to stop ovulation. And you can do that locally by, and that's the other picture, is by, if you put a barrier, like a physical barrier, like a condom, a diaphragm, a gel, you can prevent sperm from getting anywhere near an egg. That works, not perfectly, certainly, but it definitely works. And then IUDs inside the uterus, as I mentioned, can prevent. So one of them has hormones, but basically, a copper IUD is toxic to sperm, so prevents sperm from getting into the fallopian tube where it can fertilize the egg. But a hormonal IUD creates what I like to call the Great Wall of Mucus. So there's super duper thick mucus that there's no way a sperm can get through. And then finally, there's permanent methods of contraception. You can cut, burn, clip, or remove the fallopian tubes. And then that basically is a super effective way of keeping eggs in their compartment and sperm in their compartment. They're never going to get, and by never, I mean like almost never, because almost all these things have a failure rate, even the most effective ones, in the 1% range. So speaking of efficacy, this very handy chart compares the contraceptive efficacy of a whole bunch of different things. And it's not 100 couples that are having penile vaginal intercourse over the course of a year that are going to have a pregnancy. It's about 85 out of 100. And that's what that first color-coded line indicates, where it's mostly that light purple. And then as you go down through this list, the risk of pregnancy, the light purple people, becomes less. So the barrier methods and withdrawal are kind of at the top there, meaning they're the least effective. And then transitioning to fertility awareness, meaning, watching cycles and avoiding or using a barrier method during the fertile part of the cycle. And then Phexi gel is this relatively new product that also creates a physical barrier by with a gel that doesn't permit most of the time sperm from getting through the cervix. And then all the way down to these hormonal methods, which we talked about, the pill, patch, ring, the shot, and then permanent contraception, vasectomy, and tubal procedures, and then finally IUDs and the implant. And one of the super cool things about the implant is, it's probably the most effective method that we have, and it's brilliantly effective at preventing ovulation. So those other elements really are minimally at play. The thinning of the endometrial lining may be in effect, but it's really almost all about super effective inhibition of ovulation, preventing the egg from coming out. So here's another way to think about all those methods. On the green side are the hormonal methods that all work by interfering with ovulation of the firing egg, except for the hormonal IUD, which minimally does that. And then on the blue side are all of the non-hormonal methods, especially important, I think, in trans care. And those all work by preventing the sperm from meeting the egg, either by a physical barrier or by knocking off sperm like the copper IUD does on the pathway to the egg. So hormonal contraception here is also hormonal medicine. And a lot of people who are trans are using some kind of hormone to generate changes in their body that they desire. And those things by themselves are generally not effective enough to prevent pregnancy. And adding one of these other things in makes life more complicated. So the hormonal aspect of hormonal contraception can also be used for a whole bunch of benefits. For example, can treat heavy menstrual bleeding and cramping. It can make endometriosis more tolerable. It can treat PCOS or and acne and reduce cancer and reduce bleeding. And those elements, especially reduction in bleeding, can be a helpful thing for somebody who has a uterus and doesn't want to have bleeding. So when considering contraceptive options for transgender people, it's worth thinking about a bunch of different issues that some of which are completely applicable to really any person and some of which are really special in this community. So does what you're talking about require a pelvic procedure? So a colleague of mine is fond of saying when talking about long-acting reversible methods, the implant is a long-acting reversible method that you can keep your pants on to get versus an IUD. And not having to undergo a pelvic procedure can be very helpful for a lot of people. And then does it contain estrogen or progesterone, and how is that going to affect and interact with what other hormones people are on, and what's going to be the effect on, on bleeding and spotting and cramping? Is there going to be an impact on chest or breast tenderness? What about privacy and concealability? Do you need to go back to a medical provider? Or can this be something that people can manage on their own? And then is pregnancy prevention necessary? And how does this really help or hinder in that department? So, when we look at these methods again, we can sort of think about those in combination. And the non-hormonal methods have a whole bunch of benefits in that you do not have to interact with whatever other exogenous hormones people are using. And the progesterone only methods can have a very favorable effect in certain circumstances. Basically, the combined hormonal methods are, which we end up talking a lot about generally, are like, in this situation, sometimes the least helpful and the least attractive. So one of the things that I would be neglectful of talking about, because it's one of my favorite things, is emergency contraception. So if for people who've had unprotected intercourse and want a method to prevent pregnancy after they've had intercourse, emergency contraception is amazing. It's otherwise known as the morning after pill. And that can also be very helpful if you think about, like, if you're ever a person who, ever paid a bill late or were late on your homework or renewed your driver's license maybe a little tardily, or, whatever, did anything in the world that was after the where you didn't do it ahead of time. Like, I got a lot of experience with this kind of thing. You might be a fan of emergency contraception. And here's how it works. But thinking about a little bit about reproduction first explains it. So sperm obviously get into the fallopian tube, like right away. It's like minutes. It's kind of amazing. From when, if they're deposited near the cervix, they can get into the fallopian tube within minutes. And in the only aspect of male reproduction and social interactions, the sperm can survive and hang out for 5 days, while the egg really is only viable for fertilization for 1 day. And so intercourse that happens really any time within 5 days of when the egg is released can result in a pregnancy. And when ovulation occurs, pregnancy and the initial fertilization can happen, and it's days of travel through the fallopian tube, and then implantation is generally around day 6. And there's a bunch of methods that can prevent pregnancy after intercourse, these emergency contraceptive methods, and they all have different efficacy and different ways to use, but both the copper and hormonal IUD can be used for that, and obviously have the advantage of being more effective than the pills and continuing, like letting somebody have an ongoing method of birth control should they desire it for years. So up to 12 years for somebody who gets a copper IUD, up to 8 for somebody who gets a hormonal IUD. And then there are these two other oral methods. One is ulipristal acetate, or UPA, and that's available with a prescription. And there's ways to prescribe that in advance, and that's perfectly good and reasonable. And then oral LNG, like Plan B or Plan B Next Step. These are over-the-counter methods, so you can just walk into a pharmacy and you can get both of these oral methods via the mail and delivered to you with minimal hassle. And the way these things work are basically the oral methods prevent ovulation. So they really only work if you take them before the egg is released. And it does that by that same hormonal method of blocking the process where the hormones drive ovulation. The copper IUD disrupts fertilization. So if there's sperm around, it probably has a negative effect on them. And it likely prevents implantation, but it doesn't disrupt an established pregnancy. The hormonal IUD is interesting. And the main thing that in the tube that drives the sperm going to the egg is a progesterone gradient. And this is totally theoretical, and we will very likely never know the real answer to this, but that's probably somebody calling with the information on actually how this works, rather than just me guessing. But in case they don't have that answer, I'm going to guess. And basically, by putting in a hormonal IUD into the uterus, you can essentially mess with that progesterone gradient and make the sperm not know how to get to the egg and interfere with that messaging. And there's also probably some effect of just having a piece of plastic in the uterus that creates an inflammatory reaction and messes with that interaction. And should fertilization happen, it likely prevents implantation. And there's a bunch of different ways to share this information, but this is similar to a slide that Caitlin showed before. And there's multiple aspects to these. There's how well it works. IUDs work better than the pills. How soon or late you can use them after, and how do I get it? And a major barrier for IUDs is actually having to come into the office to get one. And the information on the hormonal IUD for emergency contraception is relatively new. And the data for this come from a study done right here in Utah, where our group worked with our local Planned Parenthood at 6 sites and made this care available to people. And people were willing to be randomized to one of these 2 IUDs so that the rest of the world could get information on whether the hormonal one works, because prior to this, we really didn't have any information that that was the case. And the bottom line was, among over 600 people, there was one pregnancy in the whole trial. So all of these people had had sex without a method of birth control in the last 5 days. And one of them had a pregnancy, as one person in the hormonal IUD group. And I think as far as trans care goes, that's important because this is the most effective way to prevent bleeding, which is a major concern for some people. And for people that that's acceptable to, that can be a huge upside, especially when given in combination with testosterone for trans males. So I'm going to pass back to Caitlin here, and she's going to tell you about all of these really interesting platforms that can help people make decisions about which method is right for them. So thank you very much.
All right, so there are a ton of educational tools out there, and I'm going to review a few. The first set is sort of these interactive platforms that people can engage with online. And Bedsider is up here for a reason, because they're sort of the classic old guard, really great site to find information about sexual health and contraceptive care. They have this Method Explorer, which groups methods by certain preferences. So you'll see you can sort by how effective it is, STI prevention, hormone level. And what it'll do is once you select a patient priority, it will gray out or only list the methods that align with that preference. So it can be really helpful for narrowing down choices in that way. And then if you click on any of these methods, it actually brings up a full page with information about how to use it, where to get it, cost, and then even patient vignettes of folks who have used it and what their experiences has been. Another great thing about Bedsider that a lot of folks don't know about is there's sort of a back of the website platform that's just for providers. And that lists a bunch of different articles about caring for various groups of folks. They have some new articles now on LGBTQ care in contraceptive care. Another interactive platform is one by the folks at UCSF. And this allows clients to explore their method priorities, and then it sort of assesses what good options for contraception would be based on those priorities. And it lets people print out a copy of those methods to bring to their provider visit. Planned Parenthood also has an interactive tool. It asks a bunch of different questions about what's important to a user, and then we'll propose a couple of options. One caveat for this is no matter how I try to game this, it always recommends an IUD. So you can try it out. See if you can get it to say fertility awareness-based methods. And then methods chart. So if you don't, if this is somebody who just wants to look at a paper-based decision tool, there are a ton of methods charts out there, and they are all grouped differently. So I would encourage anybody who's interested in being a source of information on contraception to look at the various ones out there, try them out, and see what works well and what resonates with folks. This is the only one that I found that specifically looks at birth control across the gender spectrum and incorporates considerations for transgender patients. This is from the Reproductive Health Access Project. And they also have this sort of classic version where methods are arranged not in order of effectiveness, which is a refreshing departure from some of the other charts out there. This is probably the most comprehensive of the methods charts out there. As you can see, it's 4 pages long. It includes actual pictures of the methods and then some considerations for use. Reproductive Health Access Project also has a chart specifically for emergency contraception, and it includes both the hormonal IUD and copper IUD as options. And then this may look a little familiar. This is from PIC, from the folks at Boston Medical Center. And what's really interesting about this method, it's relatively new. I think they unveiled it sometime last fall. And it's the result of several years of really intense research about what patients want out of a decision aid and also what providers want. And then that's sort of married together into this decision aid. It arranges methods by how to access them. As we saw from the slides earlier, where it's used, how to start and stop it, and then also includes information on effectiveness. And what's great about this is it's available in multiple languages also. All right, sort of kind of moving from the most comprehensive to less, we have a one-page chart from Reproductive Health National Training Center that similarly it groups methods by effectiveness, but also includes a couple of priorities, like how do you use it, what are the menstrual effects and other side effects. This one is updated regularly, and it has been updated to include the 8-year FDA approval for Liletta and Mirena IUDs. And then again, this is sort of the classic this was one of the methods charts that started it all. That was put together by Bedsider and the folks at UCSF. And it's beautiful and simple. And for some people who are really interested in an effective method, this may be all the information that they want to look at. But what it lacks, or what it's just not as comprehensive. So as you can see, it doesn't include all of the methods. And then other decision aids are out there. So we actually produced some flashcards in English and Spanish. We have a couple versions or a couple decks of those out on our table. And one thing that's great about using flashcards is it really allows the patient to drive a contraceptive visit. They can pick which methods maybe they want to talk about, and then you can kind of physically remove the ones that they're not interested in. And then last but not least, there's no substitute for the real thing or almost real thing. This is a kit that has demo versions of each of the methods. So patients can actually hold it and feel it and bend it and see what that method is up close and personal. This particular kit is available for purchase from birth control pharmacists. And it is a little pricey. We've heard from some clinics that have put together their own kits, which is a great option too. Okay. And then just ending on some additional resources, if this was all super interesting and you want to dive more deeply into information on contraception, there's some great resources from the National Reproductive Health National Training Center, NCTC, FP, Partners in Contraceptive Choice and Knowledge, Bedsider, Innovating Education and Reproductive Health. And these slides with the link are in the Whova app. And then my colleagues and I at Ascent, we have a number of recorded trainings available on our YouTube page. And we host a family planning echo session. Eric Torres here is our leader of our family planning echo, which is a chance for folks to connect with providers of contraception and ask any burning questions. And that will resume in September. And with that, we'll turn the time over for questions. Thank you.
While questions are forthcoming, I just wanted to say, in summary, I'm not sure what the range of people's practice is, but I did get to talk to Kara, who came here from Boise, and who's a mental health counselor. So I want to make sure that this is worthwhile, because you made some real effort to get here. Is that people have the ability, right, and should get the kind of care where they can get whatever method they want. And if you are working around that in some way and not directly providing care, you should be aligned with providers who get that message, because unfortunately, not everybody does. We're working to get to a world where that's the default, but we're not there yet. And if you work in a situation in a clinical setting where the providers that you're interacting with and work with and support the people that come through the door are not doing it, call them in to this, and hopefully you got a bunch more tools to do that effectively. Sorry to cut in on your question.
Okay. My name is Marissa McPeckstringham, she, her pronouns. I'm an LCSW at Wachoni Counseling Center. And I'm just sitting here wondering, because I've seen a lot of pictures of uteruses, if in the clinical setting with PCPs, pediatricians, what conversations are happening with male or semen producing patients about contraception? Because I haven't heard anything about encouraging male patients to use condoms, to seek vasectomies in case, and what are people in your field specifically doing to advance male contraceptives like the male birth control pill?
Awesome. Thank you so much for bringing that up. So the mention of condoms and if I didn't use the word vasectomy, my apologies. I've been a vasectomy provider from the way back. Yeah, absolutely. Those are important components of counseling and options for people. And, you know, there is a drive toward getting better and more varied methods for people who produce sperm. And one of the things that we're doing here is we're participating in a phase 2 clinical trial of a gel, a daily gel that currently is couples enroll in this study, and it has nesterone, which is like a synthetic progesterone, and testosterone, and that basically does to the nesterone in males sends the message to stop sperm production. Unfortunately, it also sends the message to stop testosterone production. Hence why there's testosterone in it as well. And this hasn't been tried yet, but is we're making progress on this, and it's still years till this is going to be available. But daily gel, and within weeks to months, eliminates sperm production. So that holds huge potential for the future. And the next phase of that trial is coming. Would be super cool. Like I can see a path in the trans community that this could be a thing that people could use, and simultaneously, right, like provide testosterone and in a really effective method of birth control, and could be used by, really anyone, because the same process of preventing sperm production also prevents ovulation. And this compound has both drugs. So you basically prevent whatever the gamete production or release is. So no eggs released, no sperm made, and also has add back testosterone in it. So there are some, I think, really cool and potential applications for trans people for this kind of medication. And unfortunately, I wish, I could say, oh, well, we're going to be getting on that today and tomorrow. The truth is, it's going to be a long road, but exciting potential ahead. And like a lot of medical care for trans people, right? Like the evidence, the medical, the clinical data for it is way, way behind where we should be. But things like this conference are going to make it happen faster than it would otherwise, for sure.
Great. Any other questions here in the room? All right, we have one other that's been submitted electronically, which is, can you speak to the experiences of many women I have worked with who have been told no when seeking a highly effective method of contraception, particularly sterilization at a young age, and being told no because they might want it later and they won't do it until that much later age?
I don't think Jamie Bade is in the room, but she's a researcher who works with our team. And I unfortunately frequently tell her, doctors suck. And she's like, no, but I work with like all these doctors and they're all awesome. And I say, and that's fortunate for you and hopefully for our patients. And there's, the lack of adherence to those very simple reproductive justice principles is something that's going to take a long time, unfortunately, to get better. And things are getting better for sure. But yeah, an adult human being who decides that they do not want to have, the ability to have a child, like they want only to not have a child, who makes that decision should have access to the care to make that happen. And, the counseling can vary for people, that's fine. But if we adhere to those basic principles of reproductive justice, we will always end up in the right place. And there's pretty much not a day that goes by where I think like, God, thank God for Loretta Ross and the amazing women of color that she worked with to develop that framework that's so simple and can guide us through really any super complicated situation, and this is not complicated. So I think, we will go a lot further as a community of providers and people to call people in, to that full range of contraceptive options. And that's part of what I said at the beginning there about, know the network of people who provide that kind of care. And I think there will be a natural selection because people will vote with their feet. And the people who are providing care that respects with full dignity the full range of options for sexuality and reproduction are gonna have more people coming to them. They're going to be more desired, and word will get out that they're doing a better job. So,
All right. I think
Thanks for
that
bringing
takes
that
us to time. Thank you so much.
Caitlin, thanks for making the slides.